This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Jeffery Ward, Chair of ASCO's Clinical Practice Committee and Associate Editor of the Journal of Oncology Practice. Dr. Ward is a community-based medical oncologist and part-time hospice medical director for 20 years, who was recently board certified in hospice and palliative care. He's based at Swedish Medical Center, which is just north of Seattle, Washington. Welcome, Dr. Ward.
Thank you.
Are there plans under, for instance, your position with ASCO and with ASCO in general to do more outreach and education to help community-based oncologists sort of reckon with all of this complex but an emerging specialty?
We're in the middle of a project right now to try and define what parts of palliative care really belong in an oncologist's office or should be, that an oncologist should be able to do in his office, and what requires a specialist beyond that. And we haven't always been in agreement, but I think that we are working towards that. And I think that once that's in place, then there can become a two-pronged education. One is an education of telling oncologists, if you're not capable of doing these things, you need to become capable because you're not providing appropriate palliative care. And then I think within that, there's also be able to say, and these are all the things that your patient needs that you not only can't provide, but you shouldn't provide, and that need a specialist. And when with that kind of information, then I think you can begin to help oncologists who think they're doing it all to discover that there's much more to be done.
So what are some of the obstacles that most frustrate you as you go through your mission?
One of the biggest obstacles is reimbursement. Right now, you can convince a hospital, and 5 years ago you couldn't, that a palliative care specialist and a team in the hospital has value because it can decrease outliers in the ICU, it can help patients be able to be discharged sooner, it provides a focus that's a two-pronged focus, their disease and the person, and that's of value to the hospital, particularly in an era where they're going to begin to be penalized, for example, if that patient is re-hospitalized in the next 30 days. It's going to be much more difficult to convince people that they should do that in an outpatient setting because that physician and that team under our current reimbursement system are not going to pay their own way.
For the patient who is in need of such care, what are their resources if they're in the community and don't know where to go?
Well, I don't think it matters whether you're in your community. I don't think most university settings are providing that kind of care either. I think that right now it becomes a little bit of a patchwork because if you have, as far as specific medical problems, you use a team of physicians within your community or within the university, and as opposed to doing that with one individual or one specific team. The other thing I think that they have to do is they have to have a frank conversation with their physician, with their oncologist, about what their goals are. I think one of the things that really happens in palliative care is to help a patient have a voice and to find their voice and be able to give their doctor their goals. And I think some oncologists are good at eliciting that, and others think they already know what is the right thing to do. Patients have to be able to find their voice.
Where is this field going now? As it is definitely, the visibility is growing, the fact that it's a recognized fellowship and one has to be certified, but where's the trend and what's the future?
Yeah, well, I hope what the future isn't is that it becomes a compartmentalized specialty that finds itself at odds with the other players. Um, the outcome of the study that said there are two kinds of oncologists was to say that the palliative care specialist needs to be perceptive enough to figure out where they actually fit in with each oncologist and to complement them and provide what they do or what they don't bring to the table on an individual basis. And they may need to be different things to different patients and to different teams. So I'm hopeful that this is going to become a collaborative specialty. I hope that they don't become primary care doctors.
Are there any other thoughts that you want to share, both on behalf of the provider and for our patients?
We are in a society where the patient has lots and lots of opportunity to educate themselves. Um, and so patients are in a position to be a much more of a self-advocate than they've ever had before. I think that where we're really going is a point where we're going to really focus on being patient-centered in the care that we give and helping patients find their voice. And whether you're an oncologist or a palliative care specialist, your first job is going to be to help patients get to that point.
Thank you. I would like to see that as well. Thank you very much, Dr. Jeffery Ward, Chair of ASCO's Clinical Practice Committee and Associate Editor of the Journal of Oncology Practice. Dr. Ward is a community-based medical oncologist and part-time hospice medical director for 20 years, who was recently board certified in hospice and palliative care. He's based at Swedish Medical Center, which is just north of Seattle, Washington.
Thanks.